Good morning, everyone, and welcome to today's installment of ClearlySo's webinar series. Last week, it was Mental Health Awareness Week, so we're running a webinar on mental health and innovations within the space. We're very lucky to be joined by two experts today, Andres Fonseca, the CEO and co-founder of Thrive Therapeutics Software, and Silja Litvin, the CEO and founder of PsycApps Digital Mental Health and the developer of eQuoo, the emotional fitness game. But I'll let the two of them introduce themselves in more detail later. Also with us today is my colleague Tendai, who leads the work that we are doing within healthcare and well-being together with me at ClearlySo. So maybe just to start, I'll give you a brief introduction of ClearlySo. We are an impact and sustainability focused investment bank. So we only work with companies who, in addition to offering the potential for market rate returns, also offer some sort of environmental or social benefit. And within the impact space, healthcare and well-being is, of course, an important subsector. And we work with companies across Europe, helping them raise money from our institutional investor network, mainly focused on Series A and Series B type of investments. So without further ado, I would like to hand over to our eminent panelists, and we will start with Silja. It would be great if you could introduce yourself, the company, and what you've been experiencing throughout this lockdown.
Yes, good morning. My name is Silja Litvin. I'm a clinical psychologist and founder of PsycApps. We use gamification to design engaging but still evidence-based mobile mental health treatments or prevention and early intervention treatments for young adults. And COVID, or the lockdown period during the pandemic, has been a little bit bittersweet because on one hand, everybody's experiencing a lot of challenges and it's quite a scary and disruptive time. On the other hand, I think it's really pushing the discourse of mental health needs into everybody's faces if we want to or not, and that's really good. Plus, people are waking up to start looking for mental health products that they probably would have done maybe in 1 year or two. So it's kind of expediting mental health and alternative mental health care solutions, which I find very positive. So it's a challenge, but at the same time, I hope that something positive will come out of it.
Great, thank you, Silja. And Andres?
Yes, hi, I'm Dr. Andres Fonseca. I'm a consultant psychiatrist and I'm the CEO and co-founder of Thrive. And we do something similar. We applications that are targeted at preventing, doing early detection and early self-management and treatment of common mental health conditions. We focus on employees mainly, so adults. We also work with charities in that space. And basically, I will echo what Silja was saying. We've seen a growth in uptake. What we've seen in our own pipeline is that people that may have taken normally about 9 months to make a decision on this, or maybe 12 months, made it very quickly. So there's been an acceleration in that sales cycle. And also we've seen a massive uptake so we deliver chat-based therapy as well. We have a group of psychologists, psychological therapists that deliver CBT-based interventions to those that need them. So the uptake of that particular service has grown to about 400% in the last couple of months. And again, it's because people may have not considered that before, but now they have. And it's interesting to see the comments that we get is basically saying we never would have thought that doing it text-based would have been a good idea, but it's got certain advantages. For example, people say that they're able to go through the session that they've had with their psychological therapist and gain insights, do reflection on that after the fact. So it's actually been interesting in that it's accelerated adoption, I think.
Yeah, thank you, Andres. And I think that's very interesting. I mean, the NHS, I think, has said that 1 in 4 adults experience a diagnosable mental health problem any given year. So it's obviously a huge number of people. And I mean, digital therapy solutions obviously have the potential to, remove barriers and improve access to mental health treatments, by getting rid of the problem of patients having to travel, increasing affordability, reducing the issue with very long waiting lists, and also to some extent mitigating the issue about the stigma that some people feel about finding treatment. It would be interesting to hear your views on what you think have been the main technological innovations or drivers, if you like, recently, and what will sort of be driving increased uptake of digital mental health solutions going forward? So if we could start with you, Silja, maybe.
Yeah, so I was on the Thrive website, and I was reading what Andres was talking about of how he actually founded Thrive. And it was exactly the same thing as myself. So we are working with the NHS, and the NHS is really, and I can't say this enough, one of the most wonderful social products of this century. I really love it. The people at NHS are highly dedicated, working their butts off and really caring about their patients, but there's not enough funding and not enough staff, and you just have these long waiting lists of people that, had they been seen 3 months earlier, or had they actually had the psychoeducation or the resilience and prevention programs 2 years, 3 years earlier, they wouldn't be in that position, right? So we're looking at digital solutions, because once you've built a good product, you just have to get in front of people. And my personal journey was, this was about in 2016. I was looking at doing my PhD, and I wanted to do something that actually added value to people's lives. So not just information, which is good, but something tangible. So I was looking at a lot of web-based interventions in 2016 that are almost as effective as face-to-face therapies or pharmaceuticals, and thought, okay, why not translate that into a smartphone? Because people are moving away from the desktop. They want personalized programs on their smartphones that they can take with them. And we designed an application. We went through a clinical trial. We could prove that we had the effect size of a beta blocker, which is like an antidepressant, no side effects. And we're like, oh, we're going to go save the world now from depression and anxiety. But one of the biggest challenges of mobile mental health is engagement, right? You can have the best app in the world, it has the best effect, but if people don't engage with it and they don't stick to it, it's not going to help anyone. So that's why we pivoted away from this very effective, but you have to be extremely dedicated, devoted, and motivated to stick to it, therapy that you do by yourself. And we said, we're looking at a generation of young adults, anywhere between, let's say, 16 and 35, and they have very specific needs and challenges, but they also have very specific consumer habits. What do they do? 70% of them are casual gamers. And there's a lot of research that shows that gaming casually is actually good for your mental health, like within the casual range. So I think the 3 big challenges that mental health has at the moment is evidence-based. Can you prove that you're doing the things that actually make a difference or change or have an effect? And is it risk mitigated? The second one is building the product, obviously, because applications and platforms are very, very expensive. And the third one is engagement. How do you get people to stick to products that are good for them? And I think that we are just in the very first baby steps. Thankfully, the market is undersaturated, and there are so many people, like there's not one treatment that will help everybody. There are different people that have different needs and react differently to different treatment methods. So you're going to have cornucopia of mobile mental health products that are tailor-made for a specific audience and work very well on that audience.
Interesting. Thank you, Silja. Andres, do you have anything to add?
Yeah, no, I mean, I agree with what Silja was saying in terms of the adoption, and the main challenge in terms of digital interventions is precisely engagement. So absolutely. So just to add, for us, it was also one of the things that pushed me and Adam Huxley. Adam Huxley is my co-founder. He's a consultant clinical psychologist. And what we wanted to achieve there was also to be able to produce a seamless journey. So it's not just about the initial part of the journey, maybe the prevention, early detection, but we come from running mental health services that are quite intense, in that we were running hospitals before we founded Thrive. And one of the things that we saw is that it's all very compartmentalized. So when you're talking about the NHS, it works very differently if you are doing, perhaps if you're trying to do prevention, there's kind of nothing very much available other than just a website, which is very good. The content in the NHS website is excellent, but that's kind of as far as it goes. And then you have to then seek help, maybe go to your GP, who may prescribe something or may send you to IAPT. And then if that doesn't work, then you have to go back to somebody who has to act as a gatekeeper again. And then you might see somebody like, say, Adam or me for a diagnosis. And then you might need more than that. Then you might need to be given some kind of an intensive intervention. So when I was a junior doctor, we had something, it was the first clinical trial of the crisis teams that have then proliferated, but they have never been kind of implemented as well as when we were doing the research. And actually, they had a lot of value. So with that service, what you were able to do is somebody who was in crisis, you were able to offer them the equivalent of being hospitalized at home. So for us, we're trying to be able to sort of seamlessly link all those phases in which any of us could find ourselves. You know, we could be well and doing prevention. We could then become a little bit unwell and then need the early detection, early treatment. You know, is what Silja was saying. How do you find your way to treatment? There's a waiting list. How do we break down that barrier? How is it seamlessly connected? So that even if I am quite unwell and I need something quite intensive, for example, at home, I'm able to sort of connect to it very quickly. So for me, the technology, the use of it is not to replace some of those traditional interventions, is to enable them to be delivered much more efficiently. For example, if I am at risk and I'm at home and I'm able to check in regularly with my application safely, I can do remote consultations, for example, and I can have visits at home, but I can do it much more efficiently. I can have the right level of intensity of the intervention at the right time. And I can also be much more in control of it. So Silja was saying that, you know, people in their 30s, 40s, 20s are used to sort of picking up their phone and getting anything delivered to their door. Why not also their mental health? So that's kind of the journey that we're on and where we see innovation happening, linking all those things seamlessly so people don't have to wait for the right intervention at the right time.
Thanks, Andres. I mean, an interesting thing that you said there was, you know, talking about prevention. I mean, a general theme within healthcare has been the shift from reactive care to more, you know, proactive, preventative care. Are we seeing the same thing happening within mental health?
Yes, so I think so. So there's an emphasis in that, at least on paper. There is no concrete, for example, if you look at the NHS and Public Health England, there are campaigns that are run to try and get people to do the right thing at the right time. There are sort of all of those leaflets. Things are done within primary healthcare to an extent, but there's no consistent, intense effort into improving prevention. I mean, if you look at what you would need to do to actually get prevention to the level that it needs to be, you would probably need to invest perhaps 1/3 of what is already invested in the services that exist. But of course, you cannot defund all of those crisis services just because you're doing prevention, if that makes sense. So if you're doing prevention, you're doing more early detection, more early intervention, that requires more resources, but you still have to keep all the crisis interventions that are very expensive available, because obviously it's not like that demand is going to go away immediately. So your prevention, the problem with that is that it may take, for a program to be embedded and be effective, it may take maybe 1, 2, 3 years, 4 years, but you have to keep the same level of funding. And that is quite a challenge for policymakers. So what we see now is that companies that we work with are investing in the prevention of these conditions because it is in their interest for their employees, for example, to be well. So therefore, they can pick up that slack, and they are the ones that are more heavily investing in well-being programs at work and things like our services, for example. But also we see that insurance companies, for example, have been quite interesting here because, you know, they do want to provide a service. They don't want people to go into a claim situation. And when they do go into a claim situation, what can they do to deliver treatment as effectively as possible, but also as cheaply as possible? So that's where digital comes in. And again, doing that prevention is tremendously in the best interest. They feel it's very much worth the expense, and they feel very much is worth investing there. So we're seeing that the prevention is not generally being invested by the NHS so much, even though there is some movement towards that. The private sector, and particularly insurance companies, occupational health companies, cash plan providers, people like that are investing heavily in prevention.
Thanks. There's been talk about sort of AI-driven or natural language processing-driven solutions to enable early interventions in high-risk groups or high-risk people. For example, there was a lot of talk about Facebook's anti-suicide algorithm and things like that. Do solutions like that have the potential to scale preventative measures, and can they work? Silja?
Yes, absolutely. I think there is a little bit of danger about privacy and what happens with the data. And I'm not quite sure that I want Facebook flagging me as potentially suicidal or in need of treatment. So I would be very cautious with the responsibility and the data and the care and who's developing those algorithms and who's actually using them. Because of course, a vulnerable population is also more vulnerable to advertising and other products than just care, right? So there has been a lot of research that shows that AI is on par and sometimes even better at diagnostics than humans. I think they are a beautiful tool to flag, or at least to keep treatment. Like Andres said, if you've already been through a chronic depression, you're at home, can flag if your patterns start going back into depression, things like that. What I would like to add with the prevention is that I think that prevention shouldn't be only towards people who are flagged, but should be kind of like part of the general education. This should theoretically be done in schools, primary schools. 3rd, 4th, 5th grade should get the psychoeducation and the skills and the resilience training that we do in prevention and prevention early intervention programs. And what I'm really hopeful about, and so I concur completely with Andres, that I think the big shift in the discourse of mental health from mental health being repairing or being perks, you have the ping pong table or the person that comes in with a massage or, say things like that, to must-haves, and that's coming from the private sector. So I'm not quite sure if you've read the Deloitte Mental Health Report, but one of the strongest things that were in there were saying that for each pound that you put into resilience or prevention training and well-being training for your employees, you can have a yield of up to, I think, depending on what you do, up to 11 pounds per employee. So it's moving the responsibility and the potential in the private sector toward the companies, which is a win-win for everyone. So the employees potentially will have programs that are onboarding programs. There aren't any more programs that you have, okay, you go through your perks list and you see in your EAP, okay, have a free yoga session or something like that. But it is when you do your security check, when you get your onboarding program, when you do your education about the workplace, you get a resilience program as well. So you're actually boosting your well-being immune system, so to speak. It's good for the employee. They get skills that they didn't have before. It's good for the employer because you have more productive, happier, less sick and less churn employees. And it's good for a society because a healthy society is going to be a kinder, more compassionate, more productive, healthy society. So that change is happening right now. And I think it's being expedited because you have all these talk about resilience and using the COVID as a challenge. And there was a big Unilever challenge that I was part of where they did it for all their 60,000 employees plus all of their clients to have a 14-day challenge to learn all these skills with the Resilience Research Center in Canada. That may not have happened without COVID. So there's pushing the situation from a perk to a must-have, and that will then most likely cascade into the NHS and to the other governmental programs. And insurance companies are picking up on that. You're saving money, good for insurance companies, good for insurers, good for everyone.
Interesting. So focus on education, training, and access rather than algorithms for now.
Yeah, well, they're good. It's just like who can bear the responsibility for flagging and using that data? And I do not have an answer for that. You'd have to have a worldwide ethics committee. And the problem is as soon as you have people in there, you have people with weaknesses that may or may not treat the data the way they're supposed to. You have the programmers with their own biases building the algorithms. There's so much in there that you just have to be very aware and conscious about what you do with that data.
Andres, given the focus of Thrive on employee well-being, do you have any thoughts?
Yeah, no, I wanted to say something about the AI side of it. I suppose I'm more skeptical about it than Silja is, in that, so maybe you do have some kind of an algorithm. You can see something like this when you use the Babylon app. it kind of takes you through a series of questions and comes to more or less a conclusion. Very often it will end up with, actually, you do need to book an appointment with your GP. But in some cases, it might make a guess as to what's going on and reassure you. Now, I mean, again, I don't see Facebook doing this for the same reasons that Silja was saying. So the way they make their money makes their incentives all wrong here. And they shouldn't be sort of screening or doing anything to do with suicide or anything like that. You need a company that is a healthcare provider to be able to sort of do that, and that understands information governance, as Silja was saying, and do those things. But in terms of AI, I think we are still very far away from being able to, for example, deliver therapy. So I suppose the biggest or greatest example is Wobot. And if you look at it, is just you select from maybe 2-3 answers. You very seldom have to type in free text because it cannot really cope with it. So natural language processing is okay for booking a table at a restaurant, but not when you're doing a CBT session, for example. So it's limited to pushing a button. So it's kind of similar to the old adventure games when you interact with a character and it gives you like 3 options to answer. That's kind of what it's like, and that is the state of the art for that now. So for the moment, I think eventually we will get there, but for the moment, I don't see AI perhaps having a limited screening role, maybe, because then you do need to validate that result. For example, you might be very low in energy, but it might be because you're hypothyroidism. So the AI is not going to pick up on that. But also in terms of intervention, I think we are not there yet. I think there still needs to be a human in the loop, which is kind of what we do, actually.
Understood. Thanks. I think my colleague Tendai has some questions for you.
I think I'll start by continuing from the topic we have at hand. We have a question from the audience. We have Imad, who's asking whether there are any good examples of resilience programs for primary schools that are engaging and evidence-based. Andre, Silja?
I think Silja works closer to that demographic than I do, so I'll let Silja.
Yes, but unfortunately, I work with young adults. I don't work with children. I know there are a few programs. There is one in America that has been very successful, and it's worked with underprivileged children, but I forgot the name. If I may, I will send you an email afterwards. I just have to look into my list of resources. I know there is a program in the States, and I think it's accessible from the UK as well, and it's evidence-based as well.
Great, thanks, Silja. I wanted to turn this topic over to investment, because you had mentioned previously how companies are investing in research, as well as, what the NHS is doing in mental health. Investment in mental health generally, we all know, has been low over the past couple of years. I mean, traditionally, compared to your traditional healthcare. I think my question is, both public and private, have you seen any investor interest in mental health care services? And if there is interest, where is the interest being channeled within the subsets of mental health care?
Yeah, I do think that there is quite a renewed interest in it. I think I mean, if you look at the recent data, so there's more and more interest in this sector, and there's more and more investors coming on board. So what elements? It tends to be in the well-being space, so well-being plus mental health. So it is in that maybe nice to have, maybe company perk, maybe that kind of space, or direct to consumer. So direct to consumer, kind of something like Headspace or Calm or one of those. So that's where the interest has been. I think is gradually shifting to perhaps more and more clinical. So there's always been a decent amount of interest in the higher acuity level. So private equity has always been very keen on, buildings with beds, with reliable incomes, because you have patients there that occupy those beds for a long time. That's always been an interesting space, and it's never been too difficult to raise money in that space. It's now is between those two areas that is traditionally been a bit difficult. So between the well-being, soft approach, maybe consumer, maybe well-being for corporates. There's been quite a few companies raising money there, and then there's been interest from investors, and also, if you look at private equity, the other end of the spectrum. But it is there in the middle that has been a bit of a challenge. There in the middle is what we are kind of think, but we've detected a lot more interest in that model that connect maybe a very early app-based intervention with something that then goes on to deliver a full counseling service. I think there's been more and more interest in that. And I mean, we are racing at the moment, and we've had quite a lot of very good, interesting conversations with a lot of people that perhaps, say, 3-4 years ago wouldn't have been interested. I think this also reflects a change in the marketplace as well. So when we started doing this, going into a company and telling them that they should be interested in their employees' well-being, mental well-being, and that they should offer this to all their employees, not just those that flag, as Silja was saying, that was like unheard of. And also we got told, no, we don't have anybody here who experiences depression or anxiety, which is basically they were just not recording it. But now they're much more interested, and I think that drives the market, and then that drives the investor interest as well. I think that's why it's changed recently.
Great, thanks, Andre. The other thing that Carl had mentioned earlier was around the stigma that is surrounding mental health care, especially just people having to admit that they have a mental disorder or an illness of any kind. Do you feel, actually before I ask that, I mean, there is the wide spectrum of how mental health has been defined over the years, because we have, your more traditional anxiety, depression, but then the spectrum is so wide that sometimes it is defined by how the person asks the question. Do you feel there's enough research going into defining mental health care? And also, what are companies doing or enterprises doing to address the issue of stigma? I'll start with Silja.
Yes, I see a beautiful trend that is now coming from a different direction. So far, everything that I've seen regarding stigma has been from bottom up, from people experiencing mental health issues that were fighting for their rights, that were trying to be seen as humans despite disorders, and it was a very huge challenge. And now we're having CEOs and CFOs and COOs and governmentals and celebrities all sharing their stories slowly but surely. So I think we're very much at the beginning. It's not normalized yet, but I think every one of us could mention maybe one or two famous CEOs who have been outspoken about their depression or anxiety and are still like top 500 Fortune companies or government employees or celebrities or things like that. So it is being broken down from both sides now, and I think that's very helpful. With research, so I'm a little bit torn, and I think Andres, as a psychiatrist, has probably a little bit more insight into that than I do as a psychologist. I think we're kind of a little bit stuck with the way we define and classify mental health, and it's probably not as flexible as it should be. We have the DSM-5 and as one of the holy grails of mental illness, and sometimes because you have to define borders of when someone is sick and when someone isn't sick, and it's just not flexible enough. But we're looking from a statistical standpoint, we have to start somewhere. So I do think there's a lot of potential there. And one of the things that I think is like the opportunity of the century for us right now is a lot of the therapies that we offer, we don't really know what does what, right? So we have CBT therapy, we know it's evidence-based, we know how it has an effect size of so-and-so, but we see it as the whole clump of therapy, so to speak. We don't know what this feature does and that feature does or that feature does, right? And so for the first time in history, we're collecting enough data to be able to see what actually has which impact on the journey of the mental health recovery or the treatment. So there's a kind of a new wave going on with micro randomized control trial within live data sets. And you can only do that if you have digital therapeutics and you have a lot of people that are using it every day. And so that's what we're doing, for example, with eQuoo right now. We know that the game as it exists right now lowers anxiety, it raises resilience, interpersonal relationship skills, personal growth, but we don't know which part of it does what, right? So in the next version, we'll be able to see each skill that we teach and each level that someone goes through has this and this impact, which means we can actually change it and see what happens. Does the effect size go up? or does it go down? What actually happens? And I think that will give a huge insight. Plus, when you have AI, I think we're years away from treatment, but we can find correlations and clusters and interaction causal links that we didn't have before. So we will be able to understand human patterns, behaviors, cognitions, and the treatments, how they interact much better, so that we can personalize mental health. And I think that is the big thing that is coming in the future for mental health.
Thanks, Silja. Andres?
A couple of comments. So yeah, that last comment on the use of AI, that is exactly the right use of AI. And yes, I agree that some of these interventions that we have are a little bit black boxes and that we don't know exactly which component does what, but also that's what for whom. So there's also individual differences that are important to consider. So again, by using data cleverly, we can look at what personal characteristics somebody has, some individual has, and which elements of the intervention are more likely to benefit this particular individual with this particular characteristic, which is what Silja was saying about personalization. I think that's going to be definitely a trend and something that perhaps digital enables more than other methods of delivering this type of interventions. In terms of the definition of mental health that you were talking about and the wide spectrum there, the diagnostic manuals and the DSM-5, the ICD-11 that we have, if you look at mental health, they go about diagnosis in a very different way than in other perhaps areas of medicine. And this is changing now. So we're looking more at first causes rather than clustering everything. You know, you were saying, you've got your depression, your anxiety, and then there's a wide spectrum. You have psychosis, you have, other conditions like that. But when we say schizophrenia, then we know now for a fact that we're talking about something like perhaps 7 or 8 different conditions that we're lumping together. And it's because they have different mechanisms. So some are more to do with maybe neurodevelopmental factors, maybe early exposures to certain things. Some are to do with exposure to toxic substances early in life. And they do have a different prognosis and a different way to go about them. So to clump them together, because they all meet that descriptive criteria, that statistical clustering that we call schizophrenia, does nobody any favors and gets us no further in trying to design the best treatment for the individual that we have in front of us. So there is definitely a much more neuroscience-informed trend now in mental health, looking at this idea of diagnosis and where we can improve and where we can get closer to perhaps what other medical specialties do. So you can say, we use the term, say, depression in psychiatry in the same way neurology used to talk about ataxia. Ataxia is just walking as if you were drunk. But of course, there's something like 17 different types of ataxia, depending on what's causing it. We don't have that for mental health yet, but that's how the trend is developing, to try and figure out exactly what are the biological, social, and psychological components for each one of these conditions, and not clump them all together, but try and separate them, which gives us a better idea of A, prognosis, and B, treatment. So that's what I see changing there.
Thanks, Andres. Yeah, it's interesting you say that. Looking at the current situation, I'd like to take it back to COVID-19. Earlier, we mentioned how companies were responding to the current crisis by providing care remotely to individuals. Do you see this changing post-COVID? And also, what key trends and technologies do you feel will be needed in the mental health care provision to make these kinds of changes? Silja?
To reflect back, if I understood your question correctly, how COVID is impacting decision-making processes for onboarding mental health care?
Yes.
So I've been reading quite a bit, and I don't know exactly where the sources come from, but I've been hearing about the mental health crisis wave that's coming after COVID, when people go back to normality. And even though I'm not quite informed on where that information comes from, it kind of sounds right. It feels right as a clinician or a psychologist. I think that people will have to gear up to find some kind of care solution that they probably wouldn't have done for another 2 or 3 years. And I think that there's a race to finding the right fit right now. And I think companies that have gone through clinical trials and that are, maybe accredited by the NHS, like our products, are going to be looked at first, because it's just kind of like a no-brainer. It's safer than having to distinguish and go through the thousands of applications and products out there, and only 2% of them actually went through clinical trials of all the products on the app stores for mental health. One of the struggles that I've been seeing, we have had a huge increase in requests for help from like universities, from CCGs and NHS, and the problem was distribution. So they have all these people that they know they need to take care of, and they want to give a product, they've decided for a product, but they don't know how to distribute that product. So how do they, as the CCG, get to that patient through the right product? So I think one of the next things that will happen over the next few months are people will be building out their digital channels of communication within their corporations or within the NHS or within their insurance companies, so that they can do a quick delivery of products, so that they can actually deliver. So, for example, if a CCG in London says, I think our young adults are vulnerable because this and this happened, that they can send out a text message with a link to a product, or that they can send an email or something like that. That does not exist right now. Some of the processes that people have to communicate with their employees or with their constituents are like out of the 70s. So I think that that is one of the big challenges that will be happening now. And then once that happens and they know how to get and reach and communicate with their people, then it's just choosing the right tool and kind of finding that product that fits best to the needs of the people that they're delivering to.
That's fine. Andre, did you have anything that you wanted to add?
No, I think I will echo that. I think one of the biggest challenges is distribution. I think companies do that a bit better because they already have internal channels with their employees, so it's easier to get the word out. But still, it is hard to get everybody aware of it. So a lot that we do to try and increase that awareness is do it in the form of psychoeducation, so that you find the topic that resonates with people, and that's how they first sort of come to you. So that serves two purposes. One, you actually do the psychoeducation, which is good. It's going to have some kind of a preventative effect, but also they know about your product and they trust it a bit more and they adopt it. So it's not so much the company, sometimes they're capturing the attention of the user. And that's where, you were asking about stigma before. So one type of stigma that we haven't talked about is the self-stigma, whereas people have become much more open in talking about these things and it becoming much more commonplace to openly discuss them. A lot of people still feel bad about themselves, about having a mental health condition, as if it were their fault or there was something wrong with them. Of course, that is linked to the condition itself, makes you feel really bad about yourself, and then you kind of blame yourself for this kind of thing, which is actually one of the barriers to seek help, because you feel like you should be able to sort of do this on your own. So one of the difficulties providing care is that, self-stigma and stopping yourself from accessing something because you feel that you should be able to do better on your own. So that, I think, is still quite a big problem. And is during this time, I think what helps with providing a remote service is that, and we know from our own data that this happens, is that a lot of people that don't even want to pick up the phone and ring their EAP or ring their GP or ring anybody like that, it's okay to pick up their phone and go into an app and request a chat and doing over text. That seems to be a very comfortable first step for a lot of people. And perhaps that wouldn't have happened without the current situation. And I don't think people are going to go back from that. They seem to find it really convenient, that fact that they can just send a text message. They don't need to show their face on a video. They don't need to go and see anybody. They don't need to ask their boss for anything. So that stigma is not no more of a barrier. They can just do it themselves on their phone. They can do it in their lunch hour. They can do it whenever they have time. They don't have to ask for time off. So I think we see a trend there that wasn't happening before. I don't think that's going to go back to the way it was before COVID. I think now that people are aware that these tools can be useful and that are acceptable and that they're quite easy to access, I don't think we'll see people going back to the way things were.
Thanks, you.
Andre. I think I'll hand over to Carl. He had a couple of questions.
Thanks, Tendai. So it's interesting to hear you both speak because you have different perspectives. I mean, Silja's talking quite a lot about NHS, and Andres, of course, you work a lot with insurance companies and private payers. So, I mean, on a sort of a high level, what effect does a country's healthcare funding system have on the ability for digital health startups to, create a viable business model? Broad question, I realize that, but healthcare provision is paid. I mean, how can that affect how companies can craft viable business models to be able to help people in a more long-term fashion? Silja?
Okay, so the question sounds like a little bit outside of my scope, but I think that the UK is actually doing quite a good job for two reasons, or three actually. The first one is the tax schemes that are there, SEIS and EIS, is extremely helpful for startups, and I don't know if anything other like that exists worldwide, where you get part of your tax, you can deduct money that you invest into a startup of a certain type back from your taxes. The second one is that the NHS is starting a lot of programs of trying to help and integrate startups. So I think that's quite helpful. And then third is I think we are leading in awareness coming from top down, like from the royal family and from PMs and things like that. So I think that a government would have huge potential of driving mental health innovation forward. And the UK is doing a pretty good job at that. But that's about kind of like where I'd like to then hand over to Andres.
Yeah, no, that's fine. No, it's actually a complicated question to answer. I think we have the most experience of how things are in the UK. So the funding of healthcare systems is very different from country to country to country. And it really varies a lot if you are going to operate in an area where they have a socialized medicine and where they don't. So such as in the States, your strategy, your go-to-market, everything else is going to be very different because the payers are going to be very different. So one of the challenges for a healthcare company in general is to figure out where it's going to operate. Also, the regulations are different, which, you didn't ask about regulations, but they are very, very important. So even if you're a digital provider, you could say, oh, that is great. I can operate all over the world. It's not as easy as that, because depending on your business model, then things, you may have to change the way you operate in different geographies quite significantly to be able to adapt to who is the actual payer at any particular geography, but also what is the regulatory system at any particular geography. What comes up to regulation and what doesn't is always an important question. So in the UK, you have three places where you might want to sort of look at funding, or look at how you can sell your product. So one is direct to consumer, obviously. So there is a private healthcare industry in this country. I have a lot of friends in Harley Street that do very well for themselves. So that exists. There is a market there. So if you're a startup and you're gearing up a product that is going to serve that market, you have to sort of consider it very carefully and see how you're going to sort of get that consumer awareness, which is going to be very challenging. Then there is the companies. Companies in the UK seem to be very interested in employee well-being. They used to be very interested in physical well-being, in general exercise, etc. And now over the last, I would say, 3 years or so, they've become increasingly more and more interested in mental well-being. So there is that, and they do want to spend money on that. They see a return on their investment. I think there was the white paper a couple of years ago, the Thriving at Work, that sort of showed companies that there's an investment case for it, and then the Deloitte paper report more recently kind of highlighted that again. So there is that. So there's a B2B market to be considered. Then there's a channel market that needs to be considered that is increasingly seeing digital as basically they must have it because everybody has it. Particularly during COVID, one of the conversations that I've had recently with one of our customers, one of our channel partners, who's an insurer, is that now it seems that everybody must have a digital channel to communicate with their beneficiaries, in their case, or the people that have a policy with them. Otherwise, you're seen as just not being able to do the job that you're meant to be doing. So they're saying, okay, so everybody's going to come up to having a digital proposition in the group of services that they're offering people. So how are we now going to differentiate ourselves? And they were talking to me about, what is your roadmap like? What can we say that is going to sort of show how we're different from all of our other competitors? So that tells you that it's really shifted now from nice to have to must have, something like this provision. And then there's obviously the NHS in this country is the biggest market of all, but interestingly it's very fragmented from the point of view of somebody who wants to sell into the NHS. So Silja was talking about CCGs. Those are the local clinical commissioning groups that operate very, very locally, and they can be alone to themselves. So you may be selling your product to one particular CCG in one locality, but then you have to repeat the same process all over again and go through tenders and all kinds of things to do it in the next place and in the next place and in the next place. And for a startup, that can be very challenging to do because you have to devote a lot of resources to doing those tenders and to communicate with all these different buyers, even though it's just one buyer, supposedly the NHS, is not very well coordinated. And the fact that you've sold it to one particular CCG does not mean anything to the neighboring CCG at all. I mean, it does give you some credence, but a lot of them are, we do our own thing because we know better. So it's always very, very tricky there. So hopefully the model for commissioning in the NHS may harmonize. There's a concerted effort through NHS Digital to standardize. So these are the apps that are up to our standards. Basically, if you're a CCG, look at these as the ones that you probably want to commission. And maybe that will make it easier for startups. This is the process that you have to go through. You have to do your trials, show your security, show this, so that you're doing things in a particular way that the healthcare regulator will approve of, the NHS Digital in this case, and then it will be much easier to get commissioned by the different CCGs. I mean, what we do is slightly different. So we also, not through this company, but through another company called Pathfinder, we operate care homes and domiciliary care services, and those are sold to the NHS. So we don't, because they always have been sold to the NHS or local authorities, is nothing new there. But what we do there is we, as part of our service, we smuggle the app. So we can deliver the service in whichever way we want, and we choose to deliver it with a digital component that they don't buy directly. What they buy is dom care, or they buy a care home placement. But what they get is a huge digital component there, which makes it easier in terms of the procurement, because they are very used to procuring a bed for an individual at a care home, and they're very used to procuring care hours to be delivered for somebody at home. That's kind of a known process. It's much easier rather than having to go, there's an app and you're going to commission it and this is how you're going to distribute it and do all the rest of those things that Silja was saying, which makes it a bit more daunting for them. So there you are. I hope I answered your question.
Yeah, that was a very, very, very good answer. So, I mean, some challenges, of course, but also lots of possibilities for startups seeking to sell through various different channels. I think Tendai wanted to run through some of our audience's questions quickly.
Yeah, thanks, Carl. So we have a couple of questions from the audience, and unfortunately we can't go through all of them. So I'll just pick a few. We have a question from Lee, who is asking, is there any best practice guidance for measuring the impact of mental health digital products?
Yes, so preferably the tool that you're working with has a system of being able to engage that through clinical questionnaires that are delivered within the product. So for example, if you start an intervention like Thrive or eQuoo, you are assessed at the very beginning of it. and then you are assessed again at the end or in the middle. So there will be a reporting of how the product has affected the person who is going through it. And I would say that's best practice, and you just have to be careful that they're using validated questionnaires and that the data is being hosted properly in privacy and things like that.
Thanks, Silja. This one goes to Andres. It comes from Taffy. Is it fair to say that it's mostly larger companies that are interested in investing more since they have more resources to survive the crisis financially? Or are you finding interest in the middle market?
Yeah, no, SMEs are very interested. So if you look at our inbound traffic from our website, we have to work quite hard to entice larger companies, actually. I think because they are expected to be approached. But if you look at the interest that is, kind of more organically generated, comes from smaller companies. So we may get, 3-4 inquiries from companies that are between 20 and 50, 60 employees very, very regularly. We have a little bit of a problem being able to onboard them at the moment because our systems are also geared up to onboarding large companies. It's a bit of a learning curve, and it's something that we perhaps never sought out, but we see happening. There's a lot of interest from small companies to try and work hard for the well-being of their employees. Yeah, so it's actually quite surprising. No, it's not the case. Most small companies are reaching out to us.
All right, I think that's all we have time for today, unfortunately. A huge thank you to our two panelists, Silja and Andres, whom have made this a very interesting hour. It wouldn't have been the same without you. And thanks also, of course, to the audience. Please join us for our next installment of our healthcare series. Thanks, everyone.
Thanks, everyone.